project and I had the gut stuff. Today I'm going to talk about the cancer immunology stuff. So this is the official title, looking at patients' immune responses to anti-angiogenic therapies for patients with metastatic renal cell carcinoma. And this is potentially paper title down the road. Some factor mediates patient variability in immune-mediated angiogenesis or response to the tyrosine kinase inhibitors, which are the anti-angiogenic therapies. So, just briefly, renal cell carcinoma is the third most common GU cancers in the U.S., and there's about 64,000 new cases every year and about 14,000 deaths every year. The clear cell renal cell carcinoma is the most common type, and it's due to the dysfunction of von-Hippel-Lindau gene, which controls the VEGF receptor. And although there are, which I'll go over the next slide, multiple different therapies, still most people develop resistance over time, and most people die when they have an advanced disease. So this is the most current guideline for the stage 4 clear cell renal cell carcinoma. So stage 4 is locally invasive disease. So the cancer has spread beyond the kidney tissues. Also metastatic, so distant metastatic disease are stage 4. So there are different scoring systems that scores favorable versus intermediate to poor risk, and those are prognostic scores. So the patients who are favorable risk, still the preferred first-line regimen is the anti-angiogenic therapies, so pazopanib and sunitinib. There was a recent big trial that came out later last year. So for the poor and intermediate risk patients, the first-line recommendation is ipi-nivo combination, which is the immunotherapy. But if they are not able to tolerate or it's not available, then the recommendation is another anti-angiogenic agent, which is cabo. But still, the pazopanib and sunitinib is an alternate agent if these are not available or not tolerated. So these these inhibitors, so one couple examples, pazo and cabo, they are targeted tyrosine kinase inhibitors, but they don't just affect one receptors, they have multiple receptor affinities. And this is another one that we're studying, the sunitinib, which inhibits the VEGF receptors directly. But because these tyrosine kinase inhibitors inhibit multiple different receptors, it has effects on the blood vessels, which expresses VEGF receptors, but also cancer cells and immune cells. So specifically for the clear cell renal cell carcinoma, they're very immunogenic. So as the tumor progresses, the immune environment switches from Th1, which is more immune suppressive, to Th2, which is more tumor promoting immune environment. And when you take out the main tumor, then the immune environment switches back to more tumor suppressive immune environment. And also, all these different tyrosine kinase inhibitors, they've shown to, so you don't need to know the detail, but they've been shown to basically modulate the immune system in different ways. And also, many large clinical trials have shown that there's a variability in how the immune system responds from one patient to another when they're receiving the same agent. So again, these are just some studies, examples showing that. So the question is why do patients have different immune responses to these anti-angiogenic therapy, and which correlates to their disease progression and treatment responses? And is that variability in the immune system inherent to that patient, or is it because their tumor is so variable and the immune system is reacting to that variable tumor? So if you ask Dr. Devin, he'll probably say it's the tumor that's different, and it's the environment around the tumor that are responding. So this is one study that came out a while back. Basically, what it's showing is that showing the evolution of one type of tumor as they divide and progresses. There are all these different genetic combination of tumors within one tumor tissue. Versus, I don't know why it keeps just going. Okay. Versus there are studies that shows that there's also a lot of variability in the immune system when patients are receiving the same therapy. And there's really, you don't know which one's the chicken or egg, essentially. There's a study just came out either end of last year or beginning of this year that used mouse model. They bred the mouse a bunch of times so that they're genetically identical, but they have tumor tissues that are genetic makeup is exactly the same. So one has one cell type, and then the other model has a different cell type, but within the tumor tissue, they're homogeneous. There's no heterogeneity within their genetic makeup. And what they showed is that when you have two different tumor cell type, you recruit different immune cells, suggesting that it's the tumor that's driving the heterogeneity in immune responses. But there are other studies that focuses more on the immune system, again, just showing that the variability comes from the immune system. So my question for this first paper is, yes, the mice have two different tumor cell types, which recruits different immune cell population, but their genetic makeup is the same. They're all genetically identical mice. So what if two people who are genetically different and eat different things, grew up in different places, if they have exactly the same tumor, are they going to have same immune environment? So that's the question that I'm interested in. So just going back, so that's a big picture, and going back to a little bit more focused, as I said, the anti-angiogenic therapy is still the mainstay, the main therapeutic method for the renal cell carcinoma, and it blocks mainly the VEGF receptor, which promotes the angiogenesis. And as everyone in the lab probably knows, that angiogenesis promotes tumor growth. So, more focused question I'm asking here is that is there patient-to-patient variability in tumor-mediated or immune cell-mediated angiogenesis? So this is just to show, again, you don't need to know the detail, but this is just to show that there are a lot of studies that have been done that basically all different immune cells affect and upregulate angiogenesis. And as you can see here, pretty much every cell type that are in the blood affects angiogenesis in different ways. So I'm using our LumeNEXT model to set up the angiogenesis model. And as you know, so I don't really need to talk about this one, but this is a US model that Tony developed. So getting the tumor explants from the kidney cancer patients, getting the endothelial cells from the tumor to make the LumeNEXT model. I'm also adding the monocytes, or not monocytes, the PBMCs isolated from the patients, all in the one system. So I'm using a little bit modified version of the LumeNEXT that Megan made. So I'm culturing the LumeNEXT line with the endothelial cells, and I'm culturing the immune cells inside and outside, stromal cells or the cancer cells, fibroblasts. So this is just an image showing these are the cancer cells, so you cannot really see the endothelial cells, and then the PBMCs inside. So to simplify and to start, I wanted to see if everything's the same, if the cancer cell's the same, and if the endothelial's the same, endothelial cells are the same, does the immune cells from the patients make difference in the angiogenesis? And I hate research. I spent many, many months trying to make the lumens with the iPSCs, and I was not getting consistent results. So I moved on to HUVEC, which is much easier, but the HUVECs do not sprout. So I'm trying to move back to the iPSC cells, but we don't have, we're low on stock right now. So just to test out my theory, I used the 2.5D, the traditional Matrigel tube formation assay. So if you don't know how it's done, it's basically done on the well plates. The pointer doesn't work. Okay, so you coat the well plate with thin layer of Matrigel, and you put endothelial cells on top of it, and you just culture them for 16 hours, and they spontaneously form these tubes. And you can either just get a face image, or you can stain them with calcine and image it. And there's an ImageJ plugin that you can quantify the angiogenesis, such as the length of the total tube that are formed, how many times it branches, things like that as a marker for angiogenesis. And you can also use the transwell system to add different cells to the co-culture, immune cells, cancer cells. So the question again that I wanted to ask was, do immune cells from different patients result in variability in the angiogenesis? So I had 4 different conditions. I had just endothelial cells with PDMC isolated from the patients, endothelial cells with cancer cell line. There are the clear cell venous cell carcinoma cell line. I have 2 different types, and all of them together. So I quantified here, showing 2 different just quantification. One is the total length of the tube. So if it's longer, there was more angiogenesis, more tube formation, and then also branching. So here, but this is just the endothelial cells, and this is the endothelial cells with the PDMCs from the healthy donor, and these 2 are 2 different patients. And this, you can just see that there's an increase in angiogenesis when you have immune cells isolated from the patients compared to the healthy donor. But this is what's interesting. Again, this is very preliminary. I've only done it once, and some of them I accidentally sucked up the Matrigel when I was washing, so note that these 2 are just NO2. But there is pretty noticeable difference between these 2 conditions. So these are, so 780, 60, and 498 are just 2 different clear kidney cancer cell line. And again, this is co-cultured with PDMCs from patient 1 and patient 2, patient 1 and patient 2. And you see the difference. And there's a picture on top that you can see pretty significant difference between the 2 donors. And you can also see that in terms of branching.
Where were the cancer cells here?
Oh, so here are the cancer cells. So the cancer cells are on the transwell, and then immune cells are in the transwell on top of the cancer cells. So yes, so there is a difference between the 2 different patients. But this is also interesting. When I wanted to look at, is there a difference in angiogenesis when you have 2 different cancer cell types? And at least in the preliminary experiment, there is no difference when I culture them endothelial cells with 2 different cancer cell types. And also, when I just culture them with the immune cells from 2 different patients without the cancer cells, I don't see a difference. So it looks like it's the interaction between the 2 and how they secrete based on that interaction is affecting the variability. So the next step, as I said, this is only 2 patients. So I want to repeat the experiment with the same patients when I get their blood, and try a few more patients to see whether there's a difference. And if I see the difference consistently, then I want to start profiling what are the cytokines that are secreting, and I'm talking with Maria to see how the different genes are regulated in these different systems. And then also, I've been profiling the immune cells, different T cell subtypes and MDSCs, so trying to correlate how does that affect, whether I could tease out different immune cell subtypes affect driving the variability. And then, I guess, moving to LumeNEXT platform. I guess I have to think about why, that's why I put it at the end, so I really need that. So, yeah. But anyway, cool. So, for this particular project, Sheena and Maria, thanks a lot for all the discussions we had, and Megan, not here, but basically teaching me how to make LumeNEXT and developing that platform, and of course Dave, Pete, and Allison, everyone else in the lab.